Hey, my name is Megan Gust, and I am the Senior Program Manager of Remind, Depression and Bipolar Support. You might have previously known us as the Depression and Bipolar Support Alliance of Greater Houston, but we are now Remind, and we have a table out front. You're welcome to take as much information as you like that kind of shares what we do and lists our resources that are here in the community. I'm really excited to introduce one of our medical advisors today, Dr. Michael McClam. And he's going to talk to us about the cost of depression. He has a very impressive bio that could probably take about 20 minutes if I went all into the details, but he's currently the Director of Admissions for the Menninger Clinic and an assistant professor at Baylor College of Medicine, and he's also worked with the VA and is a veteran himself. And so I will let him come up and introduce himself and do his presentation. Thank you.
Good afternoon. I'm Mike McClam, and like Megan said, I currently work at the Menninger Clinic where I'm the Director of Admissions there and also the Deputy Chief of Inpatient Services. What that means, I just cover for the medical director when he happens to go on vacation. In thinking about this presentation, I was asked to talk about depression. I said, sure. I mean, that's kind of that's our bread and butter. We do see a lot of people that are depressed with comorbid anxiety and other conditions. And then I started to look at, well, how much does depression cost? I mean, what is the impact of depression financially? Not just on individuals and individual families, but as a society at large. And so I started to really look at some of the studies that have been made over the last 30 years or so. Not a lot of studies, but there have been a few that try to attempt to capture what the cost of depression is in terms of direct cost and indirect costs. And we'll get a little bit into that. But before I do, let's see. Okay, so we'll discuss the signs and symptoms of depression. So we'll give some, basic overview about depression. This is not going to be a talk about the latest and greatest depression treatments. I mean, I will talk about some treatment options, but it's not primarily a treatment type of talk. We'll discuss the prevalence, discuss the treatments, and then we'll get more into the cost. So the first three will probably only take about 10 minutes or so, and the rest will take, the rest of it will be, talking about how do you estimate the cost, because that was, as I was reading, honestly, I was reading more and more articles, I got more and more confused, like, how do you figure this? Just a little bit of more background on myself. I started off in college as a math major. And so there was an old adage we all mathematicians would say, figures don't lie, but liars figure. Right? So it's trying to figure out how do you get these figures was a very challenging process for me. So just a little humor, depression, tropical depression. Actually, we were talking just before I came up here about Hurricane Harvey and the impact, the financial and the psychological and societal impact of that. So, I mean, this is pretty apropos. I kind of saw this and said, no, I got to put it in the presentation. So depression is the leading cause of disability in the U.S. for the ages of 15 to 43. So we're talking like the peak productivity age range, right? You're talking folks that are in college, folks that are just starting out in their professional careers, and you're talking about moms, dad. I mean, so that age range is pretty significant, right? Because it has a lot of impact on the future, moms, dads, things like that, and also in the workplace, right? Because that's one of the prime ages for working. And if you notice, I'm an old military guy, and most people in the military are starting to retire around this age. Think about it. I graduated in 1992 from college and joined the military right off the bat. I was 21 years old. If I had stayed in all the way through 20 years, I would have retired at 41. Right? So, I mean, we're talking this depression can have really affected my ability to negotiate a career in the Navy. So it affects more than 16.1 million adults, American adults, or about 6.7% of the population of age 18 and older in every given year. And then while it can develop at any age, the median age is 32.5. Like when I was in college, one of my professors told me that most of the things that you end up doing in life, you kind of do before the age of 35. So, I mean, we're talking if the median age of getting depression is at 32, again, right at the time in which you're, from a work perspective, you're most productive. So, I mean, it could have a significant impact. And more prevalent in women than men. So here are the symptoms of depression. We all are familiar with that. Depressed mood, loss of interest, loss of appetite, guilt, decreased energy, decreased concentration, thoughts of suicide, things like that. And at least 2 or more weeks of 5 of those symptoms, and at least one of those symptoms is depressed mood or anhedonia or lack of interest. And that's straight from the DSM, the Diagnostic and Statistical Manual. Current edition is number 5. It came out about 3 or 4 years ago, 2013. So it's a diagnosis of exclusion. So not all depression is attributed to major depressive disorder. Right? I mean, and the major thing that psychiatrists do is try to figure out when someone comes to you with these symptoms, is it a result of something else, medical? It could be a result of something endocrinological, it could be something neurological, it could be something from substances. I mean, alcohol use and other sedatives can really mimic or mask depression. Also, certain tumors can mask depression. I had a case about 2 or 3 years ago where there was a young man, he was in his early 30s, he was an entrepreneur, go-getter, he just became completely withdrawn and completely apathetic for about 1.5 years. It turned out he had a tumor, and so once the tumor was removed, the symptoms resolved. So I mean, really, you really do have to think about all other particular causes of depression, and then only then when you kind of exhaust all of the whatever contributing factors, then you say, okay, it's because of it's major depressive disorder and not depression attributed to something else. And there must be clinically significant distress or impairment in social, occupational, or other important areas of functioning. So, have you heard the old expression, beauty is in the eye of the beholder? Well, same thing. I mean, what is functional or occupational or social impairment? And what does that mean to that individual? So that's a very individualized type of criteria. So it has to be someone that's sad and down in the dumps because of something, but can still really reasonably function. And as Freud would say, to love or to work. So if you can still have relationships, if you can still do your work reasonably well, it may not be a depression. It may be symptoms similar to that based on whatever your life circumstances or whatever you find yourself in, but it may not be depression. Okay? So it's important to kind of have all these things kind of in place before we say, okay, you've got depression. So just a little historical lesson. Melancholia is what they used to call depression, and the Greeks thought that the 4 humors were some of the things that kind of helped or shaped personality. And so from the Greek, melos means black and chole is bile, so it's black bile. So that's what melancholia actually really means in Greek, black bile. I just thought it was interesting to know that. And also through the ages, you have Albrecht Dürer, who was a engraver back in Germany. Well, it was actually the Holy Roman Empire in the 15th and 16th century, and he had a very famous engraving called Melancholia. So I mean, depression and talking about depression and creativity or creative expressions around mental illness have been around for as long as we've been around, essentially. So there are some risk factors. So there's a temperament. If I have 3 kids, I don't know if any of you have children, but there's some kids are kind of happy-go-lucky. They just come out like, yay! And some kids kind of come out and go, not so much, right? So, I mean, your actual temperament, how you were born, like if you're a slow-to-warm-up kid or if you're kind of a happy-go-lucky kid, can really affect the way depression is expressed or manifest if you happen to have depression. Also, there are environmental factors, so nature versus nurture, right? So the particular social and cultural and other milieu you find yourself in can also influence the expression or the development of depression. And then genetic or physiological factors, that to me that's kind of hand in hand with temperament. Like I said, some kids are born kind of a happy-go-lucky. Some kids are born, kind of glass half empty. So there may be some genetic predispositions to certain expressions of certain types of brain receptors that make someone more susceptible or more resilient to developing depression. All right. And then course modifiers. So this means kind of interventions, a little bit more back to the nature versus nurture. So once you get depression, then what interventions have happened to occur to actually change the direction of the disease. And so there is some treatment options, of course. There's what I like, good old-fashioned psychotherapy, so take your pick. It's funny, when I trained at Baylor, and Baylor is very much I would call a balanced program. So in the training programs, we kind of consider some training programs more biologically based. So they're more focused on the medication or medical treatments. And some are more psychological based. So they're more based on the psychological, like the analytic treatment, psychotherapy. Baylor's kind of straight down the middle. So we focus on both. And one of my old instructors told me, it really doesn't matter what type of psychotherapy that you do, as long as you're present there, right? So there's been studies to suggest that when you ask old psychotherapists and analysts what was the best thing that helped a person get better from depression, they'll say, oh, it was that interpretation I made, about this person's mother, and the interpretation I made about the anger and rage. And you ask the patient, they go, well, the person was nice. They showed up when they were supposed to. They listened to me. All right. So I don't get hung up too much on the particular type of therapy, as long as there is a therapeutic relationship with someone who is attentive and good enough, a good enough fit is what we call it, to the person that's getting therapy. Right. And so, that can be a corrective experience for a lot of individuals that are in treatment for depression. And then there's the medications, and so there's a whole bunch of those. I can spend at least an hour apiece on each different medication. So safe it to say that, right now the standard of care is to either use a serotonin-specific reuptake inhibitor, things like Prozac and Zoloft and others, or to use things like Effexor or Cymbalta. The older medications that you may or may not be familiar with, such as the tricyclics or the MAOIs, they are still out there, they're still around, and we still use them. There are some people who just don't respond very well to the SSRI therapy or Prozacs and things like that. So you do have to revert to some of the older treatments. And even as I speak, there's probably like 2 or 3 drugs that are coming out that are, brand spanking new here for depression. So I didn't really list them all because it's really a moving target. There's a lot of different medications that are out there. They all are relatively the same in terms of mechanism of action once you understand the different classes that you're using. So I didn't list them all, but. So, what is the cost, right? So if you look at the other slide, right, each medication, I was thinking to myself, there is a dollar value attached to each and every one of those medications. As a matter of fact, when I see a patient, one of the things I think about now is the cost of the medication. Right? So medications won't help if you don't take them. And if you can't take them if you can't afford it. And I've had patients say to me, Doc, I can't afford this. So we have to come up with an option that I can afford. And I'll give you a personal example. I take Lipitor. I've been taking Lipitor for, 10 years or so. I just can't get my cholesterol down. And remember that old Lipitor commercial where the guy says, he runs and then he eats really well, but his cholesterol is 400 and he falls over? That's me. No matter what I do, I can't. So anyway, Lipitor is off patent, but before it was, I was in between insurance. I was in between insurance like anybody else, and I was like, well, I'm running out of Lipitor. Let me go down to the CVS and get some Lipitor. And they told me it was $500, and I turned around and walked out. I said, no, I can't. $500, and I'm a doc, right? So, it's not like I can't afford it, but the idea of paying $500 for medication for some people is exorbitant. It's a non-starter. And it's one of the things that I think some of my colleagues don't quite understand or have a good awareness of early on in practice. I think most of my colleagues that have practiced as long as I have they have that type of awareness. But when someone's out, they're like, well, I got this study that said this is new and improved. I said, yeah, but it's $1,000 for 30 days. Can your patient afford that? Well, if you can't afford it, then you're not going to take it, then it's not going to work, right? So there is a cost associated to all of these treatments, all these modalities. So the costs are quite simply broken down into direct costs. So that's the direct cost of services. So that is the cost of you going to see me and me charging you for my service, whatever that service may be. And things associated with it, like medication, or if you do ECT, or if you're inpatient, like if you have to do a hospitalization. Those are direct costs of the disease. So then indirect costs, so for the purposes of the studies that I looked at, the indirect cost was associated with lost productivity. So it was very work focused. I do think that there's a sense of, you can interpret what indirect may really mean, may broaden it out to other different costs, like cost of society, family, things like that. But from a financial perspective, they really looked at lost productivity. And the reason why I believe is that's something they could easily kind of grab onto. Like you can actually look and find some data around like insurance claims, things like that. So that's what I think you'll see when you see the next slides about the direct and indirect cost. So as I mentioned before, right, direct services are inpatient care, outpatient care to see a person out in town, medication, and then this is non-health related care costs. So this is kind of everything else that kind of wrapped up with this, you know. So these are direct attributable costs that because I have depression, I filed a claim and there is a code that has depression on it with a dollar value. That's what they could actually claim as that was a direct cost of that service or that disease. So if you look, this is a kind of a chart from several different studies. So what it's saying is this inpatient cost is about 35%, outpatient cost 48%, and then this is like the pharmaceutical cost, about 16-70% of the total cost of depression. And these are over several studies. It's kind of varied depending on what they've gathered and what information they had at the time. But as you can see, the inpatient costs can rise. It just depends on what sample they picked. Then we'll kind of give you a more or less kind of a value. But you kind of cut it off and say roughly about a third is inpatient, roughly about a third is about outpatient, and then roughly about 20% to a third is medication costs. Here's an interesting sidebar. So I trained here at Baylor, and it's not that long ago, but I graduated in 2006, and so this was right before a trial called the Katie, or right after a trial called the Katie trial came out. So this was a trial about antipsychotic medications. So these are things like Geodon or Zyprexa. Prior to that, there were no head-to-head studies of any of these medications, and so the pharmaceutical representatives would come to any of our functions and say, our medicine's so great, yeah, I mean, it's the latest and greatest, it's better than Haldol, which is an older antipsychotic. And we would always scratch our heads and say, well, but Haldol only costs pennies on the dollar, and this medication costs like $3, for a pill. So a 30-day supply for this pill is going to be $5. A 30-day supply for that pill is going to be $100, $200. So is it really that much better, right? And if it is, then is it better enough to justify the cost, right? Well, a study came out back in 2005 that basically said, no, they weren't worth the cost. And they did a head-to-head comparison of all the major antipsychotics, the newer ones at the time, compared it to an old one, and they found that the efficacy was the same. The same. Right. Yeah, the pharmaceutical reps just stopped coming around after that. I don't know why. But see, I mean, that's important when it comes to the cost, right? There's there's real money, and there's real people have to really earn it to pay for these treatments, right? So then when you talk about lost productivity, there's this term called absenteeism, which is pretty straightforward. You're not there. Right. What was a little bit more interesting to me was this thing called presenteeism. Like I'm there, but I'm not there. I'm showing up to work, but I'm not very productive because I'm suffering through the disease, but I don't have the ability to take off work. I have to go to work, so I'm just here, but I'm just kind of phoning it in. And then you have the mortality cost. This is the cost of suicide, essentially. So but how do you measure that? Right? So I'm reading the article, I'm like, well, that's great, but how do you measure that? I mean, what does that really mean? So for absenteeism, it's pretty straightforward. So it's the number of days of work times an average wage. So say you make $100 a day, you're out for 7 days, that's $700, right? So that's pretty straightforward. What about this presenteeism? That's a little difficult. That's a little tricky because you have to have some way to assess the perceived impairment wherever you're working, and you have to have a way to compare this productivity with norms specific to the type of work that you do. So a construction worker is going to have a little bit different way of rating the presenteeism as opposed to, say, me. And then you have to kind of have this estimated unproductive time at work, right? So out of the day in which you're working, those 8 hours or whatever it is it only 6 hours that's productive? Is it only 2 that's productive? I don't know. It's like a guess. I mean, so basically they have to make a couple of what I call swags, some guesses. I'm sorry, this is a busy slide, but what it's trying to show is there are a number of different ways to try to assess presenteeism. So this is what this is. It's a slide that's showing you these different questionnaires. So what it boils down to is some researcher has to go to the workplace and say, hey, I have this questionnaire I'd like you to fill out. And so the person has to do a self-assessment on whether or not they feel productive and why. And so there are several different instruments to do that. And they're based on certain things like this is a migraine disability assessment questionnaire. So if you want to talk about the lost productivity given, say, a person who suffers with migraines. Do you have migraines? Yes. I mean, how often do you have migraines? I have them every other day. When you have them every other day, well, I have to put on shades. I have to go into the dark room. So I can't work out as a construction worker in the sunlight working on a skyscraper because I got to go to a dark room. So things like that, right? And so this is a slide showing, this is from a performance metrics for employers. So it's actually, I had to dig, it's from like 2 or 3 studies, right? So like one guy used this study, then they used it from, the source study is about 10 years ago, but so anyway, it's top health and productivity costs for employers. And so they attempted to show that depression, right? Number one. And this is actually a study on 4 U.S. companies. What they're not telling you that there were 4 U.S. companies that were assessed over what their costs were for certain conditions that caused absenteeism at work or lost productivity. That's where this slide actually came from, a previous study. And so it's showing that for at least these 4 U.S. companies, it was depression, cost related to being overweight, and then kind of on the way down, like back pain, anxiety, GERD, allergies, cancer, things like that. But depression, number 1. So the presenteeism, right, that's about, it looks about roughly $200,000. And then for absenteeism, maybe about $50,000 or something like that, right? So and again, this is just a sample size of 4 companies. It's not the whole workplace, right? So we'll talk about suicide then. So the suicide rates over the last 15 years have crept up, right? 10.4 per 100,000 in 2000, 10.9 per 100,000 in 2005, 12.1 per 100,000 in 2010, 13.3 per 100,000 in 2015. So in absolute numbers, that's about 45,000 people that die a year from suicide. That's what 13.3 per 100,000 really means if you multiply it out. What is the cost? Is there a price tag for that? Does that cost anything? So how do you estimate this cost? So this is about lost productivity. Right. So when you die, you don't work. Okay. So So they estimate, okay, at the time that you die, how much lost productivity or wages would you have, or how much would you have earned that you can't earn because you are dead? And so there's two ways of looking at that. One is from the human capital method. That's from the employee's perspective. Let's just say I'm working for company X, I die. Then the day that I die, that's the day I stop working, essentially. And so from that moment on, that's the cost estimate. The human friction method, is the employer's perspective. So the day I die, I may get a replacement 2 weeks later. So the 2 weeks is what is called the lost productivity. Right? So from the employer's perspective, it's a little different than from, say, my perspective. And so there's an article, I'm sorry, we went back, that estimated that 50%, they used the human capital method. This is an article that came out about 2003 or so. They use the human capital method. So the person dies and then they estimate it all the way out. So it's a more conservative, liberal, whatever, how you want to say liberal, conservative. It's a larger estimate. They estimated that 50% of suicide deaths occurred from major depressive disorder that they can pinpoint. Because some people commit suicide and they never have a history of mental illness, right? So it's unclear what, at least documented. So it's unclear when someone commits suicide is sometimes what was going on and what the underlying thing was. So they estimate 50% of suicide deaths occur from depression. Estimated the present value of lifetime earnings based on mortality rates and life expectancy. So they look at they look at statistical tables, things like that. And then they did a fudge factor to account for future earnings and present value. So inflation. Right. So they said that there's about $9.4 billion in cost of suicide. And in 2010, $9.7 billion. So I was an old submariner. When I was on the submarine force, the submarine cost about $1 billion. That was back in 1993. Now they cost about $2 billion. So that's like a couple, 3 submarines there, if you want to look at it that way. And so the annual estimated cost of depression, if you take all the cost, so you take the indirect cost, and you take the direct cost, and you take the cost of the mortality. And I put it in a table here. And so from 1986 to 2010, so 1986, they estimated the cost to be about $16 billion. And these are unadjusted dollars. So this is a 1986 dollars. Right? And then in 2000, it came up to about 70 or 80 billion with a B. 2005, we're looking now at about 170 billion. In 2010, about 220 billion dollars. That's what we estimate the cost to be of depression. It costs a lot of money. And so I adjusted it for 2017 dollars. Okay, it's more. It's more money if you look at it from 2017 dollars. But interestingly enough, look at the trend from here to here. It just skyrockets within those 14 years, right? It's a pretty huge expense. And so if you want to look at it this way, this is kind of like the numbers. Now all the numbers come out. So the direct costs are here. It's about 25%. Indirect costs, say, more, about 3/4 of that. Right? And this is from 1993. But it's really a pretty good, pretty significant impact. So the U.S. economy is $18 trillion. So GDP for the United States right now is $18 trillion. So the cost or the value of all the goods and services produced in this country is worth this much money, $18 trillion. So depression is 1.3% of U.S. GDP. So 1%, almost 1.5% of all of the products produced in the U.S. go to the cost of depression. It would rank depression. The cost of depression would rank 40th highest GDP in the world as a separate country, in between Finland and Chile. It would rank 24th highest GDP in the U.S. as a separate state, between Louisiana and Connecticut. Greater than the combined wealth of Bill Gates, Warren Buffett, and Jeff Bezos. Right? So depression costs more than the guy who created Microsoft, Warren Buffett, and the guy who created Amazon combined. So 45% are direct or attributed to these direct costs, 5% to suicide-related costs, 50% productivity costs. So this is another way to break it out. So only about 12% direct costs are related to treatment. So the cost of inpatient services, outpatient services, so treatment is only about 12% of those direct costs. So for every dollar spent on major depression, about $2 is spent on depression-related indirect costs, suicide and lost productivity, and almost $5 is spent on direct workplace and comorbidity costs. So direct costs, $98.9 billion, suicide-related costs, about $10 billion, workplace costs, $102 billion, cost of family and friends, priceless. I think that's it for me. Yeah, that's it.